The next speaker will be Dr. Jack Shern. He's a physician scientist in the pediatric oncology branch of the National Cancer Institute. His research is focused on defining and developing new therapies for cancer to improve the care of patients with this condition. His results have really been very impactful. And today he's going to talk to us about cancer screening in patients with NF1 and reviewing the current recommendations. We're very excited to have him today because these recommendations are all very new to everyone.
Well, thank you so much for having me here, and I really appreciate the group that put this together, this wonderful meeting. I appreciate meeting a lot of you and learning from you. I'm a pediatric oncologist, so I treat kids with cancer, and I saw as this talk was being announced that everybody sort of runs for the door. Nobody wants to talk about cancer, but that's kind of part of what we have to do, I think. So I appreciate you guys sticking around. I will try and get the green button to work. It works. So I come from the National Cancer Institute and the Pediatric Oncology Branch. I got to working on NF1 because my boss is Brigitte Wiedemann, and I was seeing lots of tumors of the plexiform neurofibroma type, and then watching these things transform over time in some of our patients. And so I really thought, this was an unmet need. And I've come to sort of realize that, there's a lot of opportunity here. We can make this work a lot better. And this is a great opportunity to start to think about how do we prevent the transition to cancer. I know that's got to be important for everyone here. So what I'm going to talk about today is really just a quick review of what a cancer predisposition syndrome is. I think most of you guys have heard this and know this, so we're only going to talk about that briefly. I think the next point there is sort of what you guys really want to hear, which is the current screening guidelines. We've heard from the previous talks today that there's a lot of gray. I wish I had straightforward screening guidelines and straightforward answers for you about this is when to get this test, this is when to get this test. I'm not sure we have all the information to be able to say that, but we're learning as we go. So I think, these are important discussions to have. And then, I'm going to finish up with some new work that we're doing in our group with Dr. Wiedemann, Dr. Gross, and Dr. Sunby in my group. And here we're trying to develop a blood test that we could use to screen for cancer. And this, I think, is probably the future. I'm very hopeful that these technologies are going to start to make big differences in how we do this. And then maybe 5 years, I can get up here and say, this is the time to get screened, and this is the test to get screened with, and you are going to do this in a standardized fashion. And then hopefully I'll leave some time for questions. So you guys again know this, cancer predisposition syndromes. These are genetic mutations that happen in the germline, and NF1 happens to be the one that we're talking about here, but there's many of them. And when I say germline, I mean this happens in all the cells in this patient's body. And these can be either dominant, passed on through the family sort of every generation, or recessive, and they can sort of come and go through the families as you move forward. And interestingly, hereditary cancer, so if you look at all the cancers that happen in the US, across the US every year, 10% of them or so, we can say is because of a germline mutation, and NF1 patients would certainly fall into that. And frequently, the mutations that we see happen in genes that are what are known as tumor suppressor genes. So NF1 is a tumor suppressor gene, and it decreases the growth rate of many of the cells in the body. So it makes sense when you start to lose that you have a higher incidence of getting cancer than the general population. And I sort of came to all of this by sequencing patients' tumors, not in NF1, not in germline predispositions, but in pediatric patients. And interestingly, NF1 is one of the most highly mutated genes in sporadic cancers. So again, that makes sense that a patient that would have a germline mutation in NF1 would be at higher risk for transformation into cancer. So this is Knudsen's two-hit hypothesis. This is a very famous scientist. And actually, I think he's most famous because his wife was a pediatric oncologist. So it's actually a very interesting couple. And she was a famous pediatric oncologist that worked on cancer survivorship. So he was a pretty brilliant scientist. And this was his theory that, in your germline, if you have NF1, you have one copy of mutated NF1. I think everybody knows that. That's what gets passed on. You get one from your mom and one from your dad, and one of them happens to have damage to it. When a tumor happens, you lose the second good copy. So that's the two-hit hypothesis. So if you have one damaged copy in your germline, your cell's sort of waiting, and one of them will get a damage in that second copy. And that's what leads to the transformation to cancer. So that is exactly how it occurs in NF1. We think that the second good copy of NF1 gets lost in one particular cell, and then that's what allows it to continue to grow. So why is this more common in a patient that has a germline predisposition? Because you've already lost one copy, right? So you have a damage there, and you're sort of waiting for that next copy to be lost. So we have some dilemmas in this field, and this is one of the big ones. I wish I could look at the germline mutation that you happen to have in NF1 and say, you are more likely to get cancer, or you are unlikely to get cancer. That's what we need ideally. The reality is we don't have such an association. That would be too easy for NF1. NF1 is much more complicated than that. We do have this one called microdeletion syndrome, where you lose a copy, and it's a big loss that includes the gene next door to NF1, SUS12. And we know those patients are at higher risk for developing nerve tumors. So that's really the only one that we've ever sort of been able to put together, despite large studies sequencing lots of NF1 patients. So we don't have such a tool at our disposal right now. There's been several sort of big national and international studies where people started to look at the risk of developing cancer in the NF1 patient population. This, I think, is maybe the first one that really caught everyone's attention. This is 2016. So this is fairly new data. And what you see here is that NF1 patients get cancer in many different sites. Again, based on the germline mutation, I don't think this is super surprising. But if you look at the top there, where that blue arrow is, the sites that are NF1 specific are sort of known by everyone in this room, I would guess. Brain tumors, soft tissue sarcomas, like the nerve tumors, and then some tumors that happen in the nervous system, the autonomic nervous system. And so I think we knew that, but what this study sort of started to add is more details about the other tumor types that could be seen. And you can see there, if you sort of roll down the list, that many different sites, the digestive organs, breast cancer, we'll talk a little bit about that, urinary tracts, skin tumors, thyroid tumors, leukemias, lymphomas, and all these other various types all have a slightly increased risk, okay? But what I want you to look at is those observed numbers. These aren't common, even in the NF1 patient population. So despite the fact that we should be aware that these things happen at a higher incidence than in the normal population, the tumors of the mouth and the pharynx that I've circled there, that's 3 patients. So this is not something that you need to think of every day, but you need to be aware of it, right? Breast cancer is a similar one. It's not super common in the NF1 patient population. You see that number there is 31 in the observed, but breast cancer is common in the general population. So now if you add a little bit of extra risk with NF1, now you start to have real risk that we should think about. And there's other tumor types that sort of came out of these large studies. The thyroid gland, we don't really think of that as an NF1-based tumor, but we probably should think about it. And then other ones like leukemia, where we were always worried that, well, NF1 is a very commonly mutated gene in leukemias that we see. In this study, they really didn't see any huge increase in incidence of that. So again, I think it just shifts everything a little bit more towards cancer risk. This is the most recent study. This came out in 2021. Again, you're looking down the list. This is a laundry list of NF1 related tumors. And again, my point is that most of these are exceedingly rare, okay? So I don't want you to worry that you're going to get ovarian serous carcinoma at a high rate, but you would get it at a higher rate than a patient that just walks in off the street without NF1, okay? And what I'm going to do here is sort of walk through several of these because I think they sort of illustrate the ones that I think about or that we should think about, and then just sort of give you some more details about some of the ones that we might see more commonly. And so the first one that I'll talk about is pheochromocytoma, and this is really a benign tumor. It usually happens in the adrenal gland, which sits right on top of the kidney. Again, it's rare. It's, maybe 1 to 5% of patients will present with this over the course of their life, but many of them are asymptomatic. And many of these we really only find after the patient passes away and we do an autopsy. And there you can see, wow, maybe up to 13% of NF1 patients will have a tumor in their adrenal gland. And so that's, again, something to be aware of. Most of these present sort of later in life, in the 40s, maybe 50s, and they're very frequently multifocal, but they're not typically malignant. And the other thing is, we don't really need to screen for these. I sort of say down at the bottom that routine screening is not necessarily recommended because these become quite symptomatic when they become problematic. And that's because this particular gland makes things that become very obvious symptoms in the patient. Things like sweaty palms, hypertension, your blood pressure goes very high. And we can test for this sort of readily in the blood with things called metanephrines. We can see these things on imaging by CT scan or MRI, and we can do some fancier studies for multifocal disease. And we can cure these with surgery most typically. So this is one of these tumor types that an NF1 patient should be aware of, should think of if they have abnormal symptoms like their blood pressure shoots through the roof. But I don't know that we necessarily need to routinely screen patients besides seeing your doctor every year, getting your blood pressure checked, and discussing symptoms with your physician. So that's sort of an easy one. Another one that comes up very frequently in conversation and has come up frequently in some of the discussions today and yesterday are these optic pathway gliomas. And I think everyone in the room is sort of aware that these are very common. So 15 to 20% of our pediatric patient population, we find these. They're usually asymptomatic, but they can remain so throughout the patient's life. But I'm sure if we polled the room right now, we would find patients that had very symptomatic ones. And those are things that really need to be followed closely with your team. The thing about optic pathway gliomas is the majority of them are stable or very slowly growing. And they can even regress spontaneously. And their prevalence rates, again, can be very high, but only on imaging. So you may not even know that you necessarily have one. We frequently see these in our patient population in the pediatric clinics in patients that are quite young, and that's because we're looking for them, right? So at 6 years old, usually by an an eye exam or imaging. And so, I put down here the screening recommendations that children should really be screened by someone who knows what they're looking for in the NF1 patient population. And this should start early and be regular. So we screen our patients at least every year. And we want someone, an ophthalmologist who knows what they're doing. This can't just be someone who's not seen these tumor types before. And again, I think you heard on the last talk about how important following these patients are over time so that we can learn more about how these things evolve, which patients are at risk. And so I know there's very nice studies ongoing right now following the natural history of these tumors. And I think CTF has a big effort in this. And I think the more patients that we can get enrolled in this and follow these tumors over time, I just think that's the way that we have to make progress. So let's move a little bit more into that sort of brain tumor space. And these are brainstem gliomas. This is another one that they're not in the optic pathway, but we're sort of finding these as incidental findings in our pediatric patient population. So we find these when we look for an optic pathway glioma, we do an MRI, and sure enough, the patient will have a benign tumor sort of in their brainstem. They're usually low grade again, and they grow very slowly or not at all. So they're just sort of there, but they can certainly become symptomatic. They can present as a headache or some sort of obstructive hydrocephalus, or maybe even some of their endocrine dysfunction starts to happen. And so, I don't think in this we routinely screen for these sort of things, but if something changes in a patient, that's something that you have to be very aware of. So if a pediatric patient has a new onset seizure, that needs to be worked up completely to make sure that there's not something more serious going on. Or a new sensory or motor dysfunction in the way that the patient acts. Headaches that are sort of new or different than they have been, we want to take a deep look at that. And then, changes to vision, always you're going to want to tell your doctor about those changes in vision. So, I think my advice for these type of tumors is we're not going to routinely screen for them. There's no sort of test that you sort of need to have at a scheduled period of time. But if there are changes, you have to discuss that with your team. And I think the close follow-up with your team is really important with this. Because this is what we're ultimately most probably concerned about in this room in the brain tumors, or these glioblastomas. And the reason why is because when these happen, they're pretty bad, and the treatments aren't very good. So the one thing that I'll say is I don't want these to happen, but I don't want everyone in the room to be terrified of these things, because they're, again, rare in this patient population. They're more common. Maybe 1% of all NF1 patients will have to deal with this during their life, but they're not super common. And so I don't want people to be fearful of these things and live sort of in fear with this. The other point I'll make is that these are not related to optic pathway gliomas or the brainstem gliomas, at least as far as we know right now, that this is not something that's transitioning over time. So I don't want you to think that because your child has an optic pathway glioma that they're at a higher risk for a glioblastoma at some point in their life. That is not true. So I think some of these tumors are being more and more studied now. So we have large sequencing studies at the NCI where we're looking at these type of tumors. And there may even be a specific NF1 type of glioblastoma. And I think more and more information is coming with that. And my hope is that the treatments then will become more and more specific for the NF1 patient population. Because right now, if you have NF1, you're treated just like everyone else with glioblastoma. And again, I think the patients know their bodies the best. And these things don't hide. So if you have some new symptoms, you tell somebody. You don't just sort of sit on symptoms where you have an increasing headache or you have some sort of new deficit that if you bring that to your physician, that sort of gets worked up very quickly. And, I think, again, I wish there was a test that we could screen for these regularly. I wish there was an MRI test that we would do at a scheduled period of time. And maybe that is common for patients that would be at very high risk. But right now, if you have 1% of all NF1 patients, I don't know that everybody needs to get screened with an MRI constantly to look for these things. So again, regular follow-up with your treatment team is really how you're going to do this. And maybe future screening guidelines will have more detail about this. But right now, this is the best we can do. The other one that sort of came up in the chat that I'm sure is of interest to a lot of the women in the room is breast cancer. And this really came from these two studies that I pointed out before, where they looked at large cohorts of women in Finland and England, and then looked for breast cancer in the NF1 patient population. And what you can see is that the relative risk of breast cancer in the NF1 patient population is higher. So you can see your relative risk there at these ages. It's 6.5, 4.4, 2.6 at various ages as you get older. The interesting finding from this is that NF1 patients get breast cancer earlier. So that's a little bit different than the normal population, where breast cancer again is common, but an NF1 patient would tend to get breast cancer earlier. And so that's something that's quite important. And what you can see again, though, is that the numbers aren't huge. This is not super common, but something we have to be very aware of. And this is sort of followed up here, where you can see in this study now, you start to get even a little bit higher rates. So the more attuned the studies were to looking at the NF1 patient population, the more you saw that breast cancer certainly is a little bit higher risk than the regular population. And so here, 31 cases of all ages were observed in this big cohort study, when we really only expected to see 10 of them. So the standardized risk that's now reported is maybe about 3 times more than the regular patient population. And again, the important thing is that they're a little bit younger. So here's how that distribution looks over all the cancer sites. And again, breast cancer sort of stood out as the one that everything was shifted, so that, in the 30s and 40s, we started to see breast cancer in the NF1 patient population, where in the regular population, that's pretty abnormal. The other thing that came out of this study is that if you had NF1 and breast cancer, you did a little bit worse than everyone else. And so I think that's pretty important, and it sort of tells us that, again, like the brain tumors, there's probably some differences in the NF1 breast cancer compared to the regular population. And all the therapies that have been so successful for women with breast cancer may not exactly apply to the NF1 patient population. And I don't think that, again, would surprise anyone in this room, that there might need to be some specific therapies specifically for the NF1 patient population that has breast cancer. I think, again, there's interesting work that will be coming in the next couple of years about this. So there are guidelines for breast cancer screening in the patients with NF1. And again, these are especially less than 40. Earliest cases appear in the 30s, and your relative risk decreases as age increases. So that the women with NF1 are about the same risk. If you get to 70 years old, you have the same risk of breast cancer as the regular patient population. So that's what's to be aware of. And so what that means is we really want to start to look for the breast cancer in a little bit earlier age. So when you're in your 30s and your 40s, we want to start screening. And these are the screening recommendations. I'm happy to share these slides, and you can look these up. But I think, really what we want to start to do is do mammography in the 30s so that we can pick these things up earlier. But the caveat here is that there is still some individualized decision-making that you'll have to do with your physician. So I think you need to be screened for breast cancer if you have NF1, but there are some caveats to this screening right now. So let me sort of step into the next one, which for me is the big one, and I think one that we all think about in this room is the nerve-based tumors. And as you guys know, these things start in peripheral nerve sheaths as plexiform neurofibromas, and these are histologically benign. They develop at a young age. We see lots of them at the NCI. They, as you guys know, cause a lot of disfigurement, but they're not necessarily going to convert to something that's cancer. In most of the patients, they'll just be benign plexiform neurofibromas. What does happen, though, is about 10 to 15% of patients that have a large or a small plexiform neurofibroma, they can convert to this tumor called a malignant peripheral nerve sheath tumor. I think MPNST is much easier to say, so that's how we call it. The problem with MPNSTs are we don't have great therapies for them. So chemotherapy doesn't work, radiation is unpredictable, and so surgery really is our best option for these. And so we followed these quite closely at the NCI. And the thing that we've been able to do that maybe other groups haven't been able to do is do a natural history study. I know natural history studies now are sort of becoming much more popular, especially for the NF1 community. You heard about a couple cutaneous neurofibroma natural history studies. But this was a study that Brigitte Wiedemann set up about 20 years ago at the NCI. And she followed a whole cohort of patients and scanned them regularly because she was worried about what happens in these plexiform neurofibromas over time. And we learned a ton from this. I say we, it's the royal we, and it's mostly Brigida. I think the community learned a ton from these studies. And what we found is that these things do transform over time. And we could even start to follow things like, when do these things grow the most? So this is a study that sort of came out of the natural history study, characterizing how these tumors grow. And these are just the benign plexiforms. And what you can see is the growth rate by age. Most of these PNs grow in the younger patient population, and then they sort of sit stable for the rest of their lives. And I think a lot of the people in the room could probably attest to this in their own cases. The morbidity from these really comes very early on. So we see in the patients in the pediatric space already start to have a lot of morbidity from these. And so I think this natural history study sort of took off from there, because we can start to see, again, matching up the clinical exam findings and the MRIs about how these things change over time. And so we follow these patients for decades at a time and really get to know them and how their tumors changed, and then start to think about which ones converted to a more dangerous tumor. And the interesting thing is the longer that we've followed this cohort of patients, the more we've found transforming. And that's the key point, because then we start to see when those transformations happen. I think one of the things that we've really come to believe is that you can find these things on imaging. And the problem is in a plexiform, there can be a huge benign component of the tumor, and then within it, you start to see some sort of transformation. And frequently, these are a small nodule, so we call them distinct nodular lesions. And Brigida will now follow these very, very closely, because she believes these are the ones that will ultimately be at risk for transforming to an MPNST. Again, the problem with this is we can't tell the difference between a benign, a nodular lesion that's at risk for transformation. We don't have the tools for that yet. I think the imaging studies, some of the beautiful imaging studies that are going on right now, matched up with these natural history studies, are going to give us so much more information for this. But we've followed patients where we've actually seen this happen, because we've taken MRIs over a period of time. And what you can see is that they'll sort of start as a distinct nodule within the benign plexiform. Their growth rate will slowly start to increase, and sometimes start to increase even a little bit faster. You can sometimes see these on things like PET scans, where you'll see them now become lighting up where before they didn't. And they can be quite small at first, maybe 3 centimeters, and start to pick up these things. But if you look back in the patient's imaging over several years, you can start to see small little changes that maybe would be ignored at the time, but that's where that transformation started. And so, I think these are now called many different things in many different groups. I think there's a catch-all phrase that I use called atypical neurofibromas, and these are these lesions within benign plexiforms that we're going to follow. And what you can see there is that the growth rate change, I showed you that before, in the benign plexiforms sort of stops in the kids. But if you look at these distinct nodular lesions, they keep growing. So I think that's a marker that the MRI studies are going to help us find. And they have some distinct pathology when we take these out, but it's not obvious that this is turned into cancer until it really becomes an MPNST. So I think the pathologists are also learning a lot from these natural history studies as we start to biopsy them. So, Brigida's hypothesis is now that most of the MPNSTs arise within an existing atypical neurofibroma, which came within an original benign plexiform neurofibroma, and that this is a stage that happens over the course of the patient's life. So we, like others, have come up with a new natural history study that we're starting to follow patients over time. And this is a new cohort of patients that Brigida is recruiting. And really, we're going to be doing many of the same things that things like the Hopkins group are doing, where we're doing sequencing of patient tumor biopsies. We're looking at the natural history of the patient, looking at the clinical findings that we have. And then we're doing whole body MRIs, like Brigida has always done, looking at plexiform volume. Now, the difference here from the original study is Brigida thinks she can start to pick out the patients that are at risk. So she's starting to look at patients that have a microdeletion. I mentioned that big microdeletion, have a personal or family history of MPNST or a strange atypical lesion that needs to be followed. If a patient's had prior radiation or has a large plexiform volume, so a large volume plexiform, she thinks has a higher risk of transformation. So that's the new eligibility, and this is going to be a higher risk patient population to try and find these patients that are transforming over time. And again, they'll get sort of an NCI workup, which includes full body MRI and PET scan. And so, sitting with Brigitte and Doug Stewart, who are sort of the NF1 experts in our clinic, I've sort of summarized here their advice to patients about PNs and MPNSTs. Use your common sense, be very aware, and seek prompt and attention with your medical team for anything that's rapidly growing, painful, bleeding. This seems to make sense to me. This is common sense. If pain wakes you up at night within your plexiform, have somebody take a look at it. You may have a plexiform in an area that you're really not totally aware of. And so just because I said that the MPNSTs frequently occur within these benign plexiforms, don't ignore it if you have new pain somewhere else. Be proactive. Educate your doctor about this, because not everybody thinks the same way that we do about this. Does your back pain that you're now having have a new explanation? Should we work that up a little bit more? And seek second opinions. You heard how second opinions can be very valuable to you. Serial imaging studies we think are really valuable. In fact, we've seen patients transform from one scan to the next and have a lesion that we're worried about. And to me, that's very critical, because then you can surgically intervene. And this sort of leads me to this next idea, and this is maybe a little bit more fun, a little bit more sci-fi about how we're going to do this in the future. All right, we're not going to follow you necessarily with an MRI. We're going to develop a blood test, and we would take a blood test maybe every year and look for cancer. And I think some of this has been overpromised in some spaces. But for the NF1 patient population, where you're at risk for cancer, this makes great sense. And so, what we've set out to do at the NCI is to develop such a tool. I think imaging will always be a component of this. We're not trying to replace imaging. We're trying to put a blood test matched up with imaging and try and develop a tool like that. Tissue biopsies will always be the gold standard. If you have a lesion within your plexiform that the doctor is concerned about, they're going to stick a needle in it to try and figure out what it is. But we would like to, as a screening tool, develop something a little bit easier. Maybe a blood test would be a lot easier. And so, we've talked a lot in this conference about what is a biomarker. I think the technology for cell-free DNA, which is the circulating DNA in your bloodstream, has come far enough that it starts to become a useful clinical tool, and that's what we're working very hard on. A biomarker is really anything that could be used to measure, that we could measure and follow with the outcome of the disease. And so that's what we need from our blood test. Examples of this is very simple. We talked about blood pressure for PHEOs. That's a biomarker of a PHEO if you have elevated blood pressure. But here, again, we're going to use cell-free DNA from the blood. And the key to this is it's got to be accurate. If I tell you that your blood shows evidence of cancer, I want to be really certain that that's a good bit of advice, because if it's not, then you go looking for something that's not there, and you may end up with surgeries that are unneeded or other therapies that are unneeded. We don't want to put you at risk for that. So, these are hard to develop, but the idea is rather simple. In the NF1 patient population, we would have a blood test that we could draw a tube of blood, maybe at your annual visit. We would look for cancer in that tube of blood and say, looks clear this year, see you next year. Or we'd say, actually, there's something in this blood tube that it gives me a warning sign that maybe something is more dangerous going on. And then we'd do a further workup from there. So that's really what we're trying to do. And I can imagine something where we would do this at your yearly clinic visit. And we've teamed up with a group at WashU. Angie Herbie has been a great collaborator there, and Dr. Chiduri has been a real technical expert for us. And we've done this now in a patient population where we took patients that had benign plexiforms and patients that had MPNSTs. And we sort of took the tube of blood, did our sequencing assay, and said, did that patient have a plexiform or did that patient have an MPNST? And sure enough, what you can start to do is see things like this. So the tumor sequencing is on the top, and every one of these sort of boxes is a chromosome along the genome. And what you can see is the tumor goes like this. These are copy number variations, and this is very common in MPNST. So I think we can all see in the tumor DNA that doesn't look normal. Normal is a nice flat line. And you can see the normal down at the bottom. That's the genomic DNA, a nice flat line. We'll look here at the pre-treatment cell-free DNA of this particular patient. What you can see is those same up and downs that we see in the tumor DNA, we can see in the bloodstream. So this is a very, potentially a very useful tool, right? I can tell you when you have an MPNST, I can tell you the same changes that are in your tumor from the blood. And for this particular patient, we treated the patient and shrank the tumor. And you can see in the post-treatment cell-free DNA sample, you still see a little bit of up and down. So that, I think, means that the patient still has an MPNST, and we didn't get it all with the surgery there. So, again, this is a very useful tool, and it's not perfect yet. So I don't want to oversell it. This is probably years away from the clinic, but it's coming, and it will be integrated, I think. We've learned a lot about how to do this correctly. So we've learned some tricks that the tumor actually kicks out smaller pieces of DNA, and that's been a very useful tool to tell us exactly what is tumor versus normal DNA that happens to be in the patient's bloodstream. Again, the details of this are becoming much more worked out in the laboratory space. But what we found, and this is sort of the conclusion of this, is that, really our blood test, at least in this cohort of patients, which was relatively small out of the gate, that we were a little bit better than an MRI in telling you whether or not you had an MPNST with our blood test. And I think that is enough promise to continue to do this and to do this on a bigger scale with better and better testing. And that's what we're set up to do right now. So how would we use this in the clinic? You can start to think about all the ways you could use this. So we could follow patients over time. The red lines here are the imaging studies, and the blue lines are the cell-free DNA assay that we used. And you can see in this particular patient, sort of the imaging said there was no disease at one point, but the cell-free DNA study that we did still showed evidence of disease. And that's, again, a useful way for the physician to follow this over time as you go through therapy. Same thing in this patient, that actually the cell-free DNA was able to pick up the tumor before it occurred. And so again, this is exactly what I want to have happen, is to have a blood test that picks up this and not have to wait for the MRI to show sign of change. And this is dynamic, so this changes over time in the patient. So you can imagine then that this gets incorporated into clinical trials, where if a therapy is working and the cell-free DNA assay says that it's working, we continue that therapy. But if the cell-free DNA assay tells us that your tumor is still there or exploding, then we would switch to a new therapy. So this might allow us to do clinical trials a little bit smarter with our therapies. So, I think this is super promising. I don't want to oversell it because, again, this is not something you can sort of walk into your clinic right now and say, I want a cell-free DNA assay. But I think as you hear about these studies and how they're getting incorporated into studies, think about donating your sample, because this is important. The more numbers of patients that we follow, the better these tools become over time. And I sort of have started to develop these in the MPNST nerve tumor space. But you can imagine having a test that would also try to detect things like brain tumors or the other tumors that are occurring in these patients. So, I think there's a huge amount of promise. And, with that, I'll stop and sort of thank just a couple people. Brigitte Wiedemann is my boss, and she has been just instrumental in helping us develop some of these tools. And Taylor Sunby in my group is sort of a young investigator who's really spearheading a lot of this cell-free DNA assay development. And I'll take questions.
We have quite a few in the app too that I will get to.
Thank you so much. This presentation was amazing and really helpful. You mentioned the clinical trial at NIH. Is that underway, or is that already full, or just still to come?
It'll enroll this fall, so
Okay.
Stay tuned and shoot me an email, and we already have sort of a list of patients that are interested. So
Great.
It'll start this fall, we hope.
Okay. Well, I'll speak for all of us, parents and probably adults too, with plexiforms. It's very exciting and appreciate all your work.
Is having a full body scan recommended, and will my health insurance be able to cover majority of the costs because I'm an NF patient?
Yeah, I mean, this is sort of a great question. So I work at the NCI, where MRIs head to toe can be done sort of like this with no insurance. But in the real world, I'm not sure that that's how it happens. And so, while we follow our patients every year on clinical studies, head to toe MRIs, I'm not sure that's reality for everyone. But what I would say is, if you have a large plexiform, you're probably going to want to follow that over time. And whether that's every 1 or every 3 years, I think it's going to be highly dependent. I wish there was a standard. There's no standard. And again, these natural history studies allow us to develop these type of standards. So I think those, I don't think there's a standard way to answer that. Whole body MRI may be useful for some.
Excellent. This was a wonderful talk. Is the cell-free DNA currently used in any other cancer?
Yeah, that's a great question. So these technologies are exploding, and you start to think about things like common cancers like breast cancer, prostate cancer, and there you start to see things moving into the clinic. So that gives, again, another reason for me to have great hope that we can sort of quickly do this. And what we have found is that this is a field that industry is super interested in. And for somebody in pediatric oncology, where we're always begging industry to help us do stuff better, this is one of those things where industry has been sort of, really interested. And I think that's going to accelerate the way these things move in, because we'll be able to build on all the infrastructure that's built for other tumor types, and that'll just move things much quicker, I think. So I'm excited about that.
My daughter has an optic nerve glioma. How will we ever know if it is not cancer?
Yeah, so the reassuring thing is that the optic pathway gliomas typically don't transform. So, I think you can feel quite reassured that following that over time is the right thing to do. That doesn't mean that it won't be symptomatic and that there won't have to be some sort of intervention to sort of preserve vision, but the chance that it becomes malignant or something like that is remote.
I want to thank you for educating us. Two things. One is, you mentioned when you were talking about the glioblastoma, and you were also talking about the breast cancer, that the tumors may be different, that we may need a specialist who knows more about NF to treat those. Is it because the tumor is biologically different, or is it because the NF, the person is different and reacts differently to treatment?
That's an amazing question, and I think it's both. So in the brainstem or in the glioblastoma situation, it seems like there's a specific subtype, a biologic subtype that the NF1 patient population gets, and that also looks like it's true in the breast cancer space. So there's something unique about having NF1 and the tumors of the breast and the brain. So that's a one point. But I also want your treating oncologist to be very aware that you have NF1 too. I think that affects sometimes the way that you can tolerate different drug regimens. So it might influence the way that we use the different drugs. It would certainly influence the way we use radiation. So, I think you made the point for me. Both of those are incredibly important.
Thank you. And then the other question is, you mentioned some caveats with the screening for breast cancer, but I don't know if they were on the slide and I missed them, or if you could just share that a little bit more.
Yeah, no, I think that my point is that screening should start early in the NF1 patient population. And, those recommendations, I can get those to you. I mean, those are sort of published recommendations for how to follow patients with breast cancer. But I want you to, I sort of think of breast cancer as a 40s and 50-year-old kind of disease. In the NF1 patients, I want you to think about this earlier. So start to think about it even in late 20s.
How can you donate a sample to the National Cancer Institute?
So there's lots of ways. I think we're gearing up to try and study this cell-free DNA screening assay in a bigger patient population. So I think we'll have studies for that. Enrolling on one of our clinical trials or our natural history studies are great ways to do it. And I think anyone should feel free to email anyone at the NCI and say, how can I help? How can I get involved? I think you'll find that we're super responsive. We have a great interest in this. So,
if my child has 2 optic pathway gliomas, how often does he need to see an ophthalmologist?
I'd say at least yearly. And it depends on the case, but at least yearly.
If your child has a PN, how often should it be scanned, especially if they are completely under the skin and you can't always see changes?
Yeah, I mean, a lot depends on age and the size of the tumor and what's been seen on the previous scan. So, you certainly want to get the baseline. And then what we do is we follow everyone yearly. That might be more than what can be done in all clinics. But if you have a big plexiform neurofibroma where something has been seen previously, I'd want to see that at least yearly with a scan.
When you have malignancy symptoms in a plexiform, how are you able to know if it's benign or cancerous?
So this is one of the biggest issues, right? So I think of pain as one of the maybe the most likely thing. So we frequently have patients that have very painful plexiforms. I'm sure everyone knows that. But a new pain or a focal pain within the plexiform that's different, that's what we see when it starts to transform.
When you have a biopsy of a low-grade glioma, why not just remove it before it becomes a high-grade glioma? And this would be for a 21-year-old female.
Yeah, I mean, there's lots of caveats to biopsying versus taking something out, especially in brain tumors. So there you have to be worried about, all the side effects that could come along with a resection. So I think, a lot will depend on discussing that with your team and figuring out, well, is a biopsy useful or is something else indicated there?
So if we have a higher chance of developing breast cancer and earlier, why hasn't the AMA done anything to push for earlier mammography?
Yeah, those screening guidelines are changing. So I think instituting that earlier is now accepted. So I think that is changing. And I think your team will certainly push for that to include mammography earlier.
One more question?
Because the coffee break is next.
All right, one more question. Can my NF clinic test my son's blood for cancer if he has a known PN? It seems the tech already exists for a blood test to indicate cancer.
Yeah, I'm not aware of a NF-specific test, but and a blood test, but certainly blood tests can be used to detect cancer. A lot will depend on the particular patient. What we are trying to develop is a specific test that could be used to detect cancer in this patient population.
Excellent. We thank you very much for a fascinating and exciting talk. We're all looking forward to those results in the future. And if there are any other questions that you have for Dr. Shern, please submit them either through the Hoover app or give them to Kate Keltz, and we'll direct them to Dr. Shern.
Yeah, I'll be at the coffee hour, so.
Exactly. So we'll take a short break before the next session. Okay, thank you.